So
Yes.
now I invite Dr. Sonu Goyal, our next scientific committee member, to start with the next presentation. Sonu, over to you.
So thank you, Amit. Am I audible?
Yeah, you're audible, Sonu.
So let me introduce the next speaker, Dr. Sonai Mukherjee, and she'll be talking on From Tears to Smile, the multifocal IOL. And the lead discussion for this talk would be Dr. Virendra Sagwan and Dr. Namrata Sharma. Dr. Mukherjee did her fellowship in phaco-refractive. She is a consultant at the Anandai Hospital, phaco-refractive UV and comprehensive ophthalmology in Jaipur, Rajasthan, an NB accredited postgraduate teacher, a member of ESCRS, APSCRS, has a lot of publications, indexed and non-indexed, and has won APO Achievement Awards and free papers and posters in various national and international conferences. She's an active member of the scientific team for Rajasthan Ophthalmological Society. So all to you, Dr. Mukherjee, you can start sharing your screen now.
Thank you so much, Dr. Sonu sir, for giving me this opportunity. Very good evening, respected chairpersons, and all the speakers and the moderators. So we've been talking about the unhappy patient. So my unhappy patient from tears to smile is a multifocal lady. As we know that this is an era of quality of vision, and this is a new era of expectations, and we all have 2020 unhappy patients, and 2020 unhappy patient is not acceptable to all of us. So my patient comes frowning to my OPD, and she's a 52-year-old lady. She has undergone a right eye phacoemulsification with a multifocal IOL, which is an Alcon restore, around 8 weeks back elsewhere in a metropolitan city. And she constantly complains of diminution of vision. She's not happy with her distance vision nor with her near vision. She constantly complains of dysphotopsia like features. She's not willing to wear any kind of glasses, and she doesn't want to get the other eye cataract operated at all. She doesn't want us to touch the other eye. So let's now open the mystery. So let's see what we have to unfold. First of all, her visual acuity is uncorrected 624. With pinhole, she is 6/6. So at least we know that inside the eye, there is nothing abnormal. Her refractive correction, she has an induced myopia with induced astigmatism. She's undergone an ND-YAG laser capsulotomy around 4 weeks back in the same center. And she had an OCT report, which was normal. We did a dilated fundus examination, did a periphery to rule out any more retinal pathologies, which was absolutely normal. So next, very important, a dilated slit lamp examination. We suspected could be it is a tilted IOL, a tilted lens. So as we all know, a post-operative refractive surprise after cataract, you have to do an IOL power calculation, rule out any miscalculation in the lens power. So she had a restore lens card, which was showing a power of plus 21. We did an IL Master 700, which was showing 21.5. It's absolutely fine. So we have to rule out any ocular surface abnormalities. Her cornea looks normal. Her topography, her pentacam was absolutely normal. So then we did an eye tracy. So in an eye tracy, what we do is we have to check for centration or tilt. So there is a radial ruler which overlays the IOL, which will provide us a centration information. And if it is a non-circular, if the IOL is non-circular, it might be tilted. So in a tilted lens, the map is always from colder colors to warmer colors. So one side there is a cold color and the other side is a warm color. So this is a paper analysis of this patient. You can see that the higher order aberrations of the internal optics is relatively high, which shows that it is a tilted lens. So now we have to unfold the mystery more. So we take her in the OR and we see why the lens is tilted, and we have to reposition this lens. So we did a repositioning of the lens. So first of all, as we all know, we have to first counsel the patient. We take the patient inside the OR, make 2 side ports. As you can see that in the center, there is an opening which has been made by a YAG capsulotomy. We put enough amount of OBD, a viscoelastic. And then with the right hand, I use a dialer and I try to nudge the lens, and I pick the lens, the optic, and suddenly I find that the superior haptic is folded reverse. So this haptic, which should have been the opposite side, it is reverse folded. So what I do is I use another dialer with my left hand and I turn it around and I turn it in the exact position. So both the haptics were in the bag. The only thing was the superior haptic was reverse folded. That's the reason it was nudging the lens and causing a tilting of the lens. After this, I do an irrigation aspiration. I wash the OVD properly. And you can see the lens is well centered. You can see the Myers in the center. So hence, my patient was from unhappy to happy. She left our OPD with congratulating us with a vision of 6/6 and N6. And she also went for the other eye cataract surgery with the same lens. Thank you so much. And thank you for allowing me to present, and thank you for listening.
Thank you, Dr. Mukherjee. And the lead discussants would be Dr. Sangwan and Dr. Namrata Sharma, ma'am. Yes, Dr. Namrata, ma'am.
I think it was a very nice presentation, done very well. Only thing is that from what I could gather, the surgery was done 8 weeks ago, Sonali.
Yes, ma'am.
And then somebody's done a YAG also
YAG around 4
within the
weeks,
next 8 weeks, and there was quite a lot of PCO, which has,
Ma'am, that
occurred
could be because of the IOL tilting that could
Yeah.
have been so much of PCO formation within a period of maybe 6 weeks.
Yeah, that's because there's not enough. This gap between the IOL and the PC is a lot more than desired. The IOL is not stuck to the back of the PC as one would desire, and that is why cells have migrated there, and it has led to this. So I think very nicely managed case and very nicely shown problem. This is a rare thing, and this you'll only come to know after you deal with it, after you try to tackle a lens which is tilted, and also talks volumes about the technology iTrace, which picked up the tilt and helped you to arrive at a conclusion. So this has a very informative and educational case, I should say.
Thank you, ma'am.
Dr. Sangwan.
Was just Dr. Mukherjee, was this when you dilated the patient preoperatively, the kinking of the haptic was visible or not visible?
No, sir. Actually, the kinking was not visible, but the lens was also was looking a bit tilted, but we could not see whether it was on the other side, because could be she was not fully dilated that much, because we were not able to see the other superior part. It was a superior haptic, sir.
Very, very nicely presented and very well managed. Thank you and congratulations.
Thank you, sir.